It's my pleasure now to hand over to the local hero or international hero, Professor Ignacio Blanco from Barcelona. He's a clinical geneticist at the Germans Trias Hospital in Barcelona, and he's a Spanish board certificated in general and digestive surgery and also accredited in human genetics by the Spanish Society of Human Genetics. He was also the head of the thematic group for NF in the Germans Trias and co-author of the guidelines for tumor surveillance in NF1 and for schwannomatosis, so one of the leading experts in the world. So I'm very happy that you are here today to talk about transition of care and clinical management of adult patients with NF1.
Thanks a lot to the organizers to giving me the opportunity to be with you and to share what I learned about the transition process as an adult medical doctor. Here are my disclosures. As you already know, neurofibromatosis is an autosomal dominant disorder that affects many organ systems. And because of that, there can be many types of manifestations. The defining feature of the neurofibromatosis is the neurofibroma, benign tumor of the seat tumor of the nerve, sorry. But there are also other manifestations like pigmentary lesions, skeletal abnormalities, learning, cognitive and soft skill defects, low-grade tumors, and also malignancy. We know that this condition is gradually progressive through the entire life of the person. It starts in the birth, but manifestations can appear through all life of the patient. The timing of the clinical manifestations, the rate of progression, and also the severity of the complications varies a lot. There is not two patients that can manifest the same, either in the same family. We already know that some of these manifestations appears at different time points: birth, infancy, early childhood, and also adulthood. As you can see, many of the new manifestations appears in the infancy, in the childhood. However, patients, because NF1 is a chronic disease, has to be followed through the entire life. And many times we forget about that. And also, adolescence is a key moment in the NF1 patient's life, because probably we can say that it's the worst prognosis group because of the poor treatment adherence and discrepancies between chronic age and maturity in this patient. Also, is the moment where patients are transferred from a safe environment, that is the pediatric medicine, to an aggressive medicine, that's the adult medicine. In the pediatric medicine, patients have a nice environment. They have a comprehensive and a structured assistance, a personal care, a multidisciplinary approach. And usually, when they move to the adult medicine, is a fragmented care, a patient dispersion, and many times a lack of specificity policies of translation. And families are scared of that moment. They are scared because the fear of care discontinuity. Families overprotect the child. Sometimes there is disability, immaturity, and desire for connected autonomy. And for that, it's so important to talk about the transition process. And starting that is a process, it's not a moment. The pediatric has not to send the patient to the adult care. It's a process. It's a process that has to be planned, anticipated, and coordinated. This is very easy to say, but very difficult to do. And when we have to do it, we will go later again, but that process has to be individualized because it depends on the patient maturity. We have to plan this process. And also, we have to ensure that the patient receives the correct management during that period. Sometimes we get lost in the process. And we have evidence that if the process is planned, the prognosis of the patients improve. And also the quality of life of the patients increase. As I told you, the process has to be individualized, has to be gradual. It's not a moment. We have to think and we have to plan. And has to be carried out in different stages. All the team that is working with a patient has to think when to do this process and how to do it. When, it could be easy when the patient is prepared. And if we want to have a patient prepared for the transfer, we have to plan how to do it. And also, we have to think about the emotional and the clinical moment. For some patients that are okay, any moment is okay. However, when the patient is in a critical point, receiving a special treatment, I don't know if it's any moment, the right moment. And how to do it? There are many things to do. It's not write a paper and send to the adult doctor. We have to prepare different points. In the case of NF1, adolescence is a particularly delicate moment. The child is growing. We know the neurofibromas appears, and many, many things to take into account. They have been treated in a very safe environment. And now they are passing to a new scarring system, at least in Spain. And we have not forget about family. Family is the one that is taking the care of the child for a long time. And they are very safe with the doctors in the pediatric area. Now is the moment for the patient. Families, sometimes they feel that they are not taken into account and are very important in the process. The American Academy of Pediatrics say that there is at least 3 stages. One is the pre-adolescence, 12 to 15, adolescence, 16 to 18, and maturity for young adults, 19 to 25. And we have to plan the transfer process, taking into account these 3 stages. We have to initiate the transition plan in the pre-adolescence. We have to empower the patient and the family, mainly in the adolescence. And finally, when the patient is prepared, we can transfer him to the adult. And we have to identify barriers. Sometimes the fears of the families or any other barrier, because if we identify these barriers, we will be able to coordinate a transfer plan and also to will be able to make a better life to the patient and the family. Thinking in these 3 stages, we can start planning the transfer. We can think about the conditions. We can explain the patient, the child, in the pre-adolescence, and to empower the patient to be well known about his disease, and their knowledge has to be in a high level. We can think about also medication. The patient has to be able to know exactly what is he's taking and why. Life and prevention. We never talk about family planning in the childhood, but we have to empower the patient to know everything about reproductive counseling, infections, transmitted diseases, etc., at the end of the process. And also how to relate with the doctors. In the infancy, parents are taking the responsibility. In the adulthood, the patient is responsible to inform the doctors. As I told you, there are many stakeholders involved in the transition process. It's not only the pediatrician and the adult doctor. There are many other stakeholders: family, patient association, case manager, adult hospital team, primary care. And also, everyone has to think that this process has to be person-centered care. The patient is the center of all actions, and we have to think that that's an important point. And I will stop a little bit about case manager, because in our experience, the case manager is the pillar of the transition process. Usually, these case managers are nursing. They are specialized in neurofibromatosis. They try to facilitate the coordination in this process among the pediatric hospital and the adult hospital. This case manager acts as a, I will say, a link between patient, family, and doctors from the pediatric area and from the adult area. And she's taking the lead in the integration of all the management of the patient. When I say that we have to individualize the plan, the first thing is that we have to personalize with the patient. We have to identify which patient has to be transferred, because everyone is different. And then we have to contact the two doctors, pediatric and adult. We should schedule a common visit in order that the patient and the family know the adult doctors in the safe environment. We should eliminate as many barriers as possible, and we have to prepare a good documentation with all the information that has been to the pediatric time that the patient has been followed, all the medical history, relevant events, therapeutics, the current therapeutic plan, but also information about disability, handicaps, work autonomy, family, social, and legal situation. We need to know everything in the adults. Yeah. Probably you know that here in Barcelona are the two national reference centers. The pediatric one that is coordinated by Dr. Hector Salvador, and the adult one that I'm the coordinator. We have been working in this transition process for a long time, and we need still a lot of help from our CEOs in the hospitals. But okay, we have been dealing, and I think that the process is more or less effective. However, this is not the situation in the rest of Spain, and I think that also is not the ideal situation in the rest of Europe. Because of that, in Spain, we are conducting a project in order to standardize the transition process, to look for the key points, maybe to perform a checklist of things that has to be done. And the same we are doing in Europe. We have right now a working group among the different ERNs that are trying to standardize this transition process for all rare diseases, included NF1. And with all of that, I would like to thank our team in the reference center in Barcelona, also the patient association that is, you are helping us to understand better what is carrying a patient or a family with NF1. Also colleagues from the research area and all the associations that are helping us. And thanks a lot for your time.
Thank you very much, Ignacio. We are heading, well, maybe one question, Ricardo, quickly, before we head into a break.
First of all, thank you very much for your presentation, Dr. Blanco. It was very comprehensive and exhaustive, so thank you. My question is regarding some of the topics that you've been talking about on the transition. I was very much interested to the sexuality part, because you, of course, have been saying that we need multidisciplinarity and personalized treatment according to the different patients, because not every adolescent is the same, and the importance of the families is very evident. We have to engage them, but which is the way? Because, for example, in sexuality, not talking about sexuality when you are an adolescent or a young adult, do the people, the families has to be present? Do we have to refer them later? Which is, I mean, of course, everyone is different, but in order to have a standardized approach, which is based on your experience, yeah, like, what do you recommend? Thank you.
I think that you make a very good point, because, as I told you, we have to personalize everything. What I do usually when I receive a patient from the pediatric area is to ask him to explain me what he knows about NF1, about the disease, the problem, and then I try to know how much he knows about the possibility of to pass the disease or not. And also, I have that conversation with the family. And if you keep an eye on the parents and the patients, you feel how difficult it is to talk about different things. If I found that the child or the girl is having troubles, I prefer to talk in a separate way. And I don't like to explain everything in the first date. The first day I can approach how is the hereditability, how can we have a correct family planning. And then in another moment, I can explore sexual relationships, how he feels or she feels during this moment, because that also gives us some clues. And I have also the opportunity to work with our psychologists, that they know that the adolescence is a key moment to talk about everything. We know that the skin manifestations can be a barrier for the, and then we create a plan. We don't care to have 2-3 visits in the first year of having him. This is what we are trying to do.
Thank you so much for this wonderful talk. We are